to the Interim Joint Committee hearing on Health and Family Services. We, as always, have a very full agenda. A few reminders before the roll call. Members that are participating remotely, everyone should be muted unless you are actively speaking in the meeting. And please use the chat feature to notify staff if you want to be recognized for a question or a comment. When you are answering the attendance roll, please indicate if you are in your LRC office or if you are participating remotely. Okay. Secretary, if you could please take the roll.
Senator Rocky Adams, Senator Berg, Senator Carroll, Senator Givens,
Present in the room.
Senator Harper Angel,
Present remotely.
Senator Howell, Senator Kerr, Senator Meredith,
Present in the room.
Senator Nemes,
Present in the room.
Senator Wise, Representative Bentley, Representative Bowling, Representative Bray,
Present remotely.
Representative Birch, Representative Dotson, Representative Elliott, Representative Fleming,
I'm in the room. Present.
Representative Frazier,
Present in the room.
Representative Marzian,
Present in my district.
Representative Gibbons Prunty,
Present remotely in my district.
thank you. Representative Rayburn, Representative Raymond,
I'm present from my district.
Representative Riley,
Present in the room.
Representative Sharp, Representative Sheldon,
Present remotely from district.
Representative Tate, Representative Weber,
Present in the room.
Representative Westrom, Representative Wilner,
Present remotely.
Chairman Alvarado, Chairwoman Mosier.
I am here. Okay, we have a quorum established to do business, and I would just like to, first of all, welcome everyone. Thank you for being here, whether you're in person or remotely. Unfortunately, Senator Alvarado is not able to be with us, and actually Representative Dotson as well, and several of our presenters. We would just like to send out our thoughts and prayers to Judge Chris Pace's family. I know that his funeral is happening now, so a tremendous loss, I know, to Clark County and certainly to his family and all who knew and loved him. So we just send out our regards to everyone involved. We will need to approve our minutes from September. Thank you. We have
Second.
a motion and a second. All in favor? Aye. Thank you. So, moving into our agenda, we are pleased to have some folks with us today to discuss assisted living. And actually, I think what I'll do first, I think I'd like to go ahead and approve the regulations, review the regulations first, since we have a number of people here in person with us and online who are available to discuss and answer questions should we have any. We have a long list of regs which have been referred to us to consider today. All members were sent out the regs and hyperlinks. Are there any questions or any concerns about any of the regs? Thank you. So seeing no questions, we have a motion to review those regs. Any, do we have a second? Second. Thank you. Oh, okay. We're just going to review these. We actually don't need to vote on this, but thank you very much. We will consider all of the administrative regs reviewed, and we will move on. So first, we have with us the assisted living and long-term care update and priorities. We have, I'll just read off the folks that I have here on the list. Some are remote and some are here in person. Mary Lynn Spalding, President and Chief Executive Officer for Christian Care Communities, I guess is remote. And we have Tim Vino. Just come on up to the table if you're here in person. Betsy Johnson, Bob White, and Mark Lee. So thank you very much for being here. I look forward to your presentation. We are hopefully going to get a nice overview of our assisted living care in Kentucky and long-term care, and then hear a little bit about your priorities. So go ahead and introduce yourself for the record and proceed with your testimony.
Hi, I'm Betsy Johnson. I'm with the Kentucky Association of Healthcare Facilities and the Kentucky Center for Assisted Living.
I'm Tim Vino with Leading Age Kentucky.
I'm Bob White, Executive Director of the Kentucky Senior Living Association.
And I'm Mark Lee, Paragon Development Consultants.
Okay, thank you. If you can all make sure that your microphones are on, that the green light is on, then we'll be able to hear you.
And I'm Mary Lynn Spalding, remotely with Christian Care Communities.
Okay, welcome everyone.
Okay, well, my colleagues in long-term care voted me first to go, so I'm going to start off with just, first of all, good afternoon, and thank you, Madam Chairwoman, for inviting us today and members of the committee. Our association represents the entire continuum of care, assisted living, personal care, and skilled nursing facilities. We represent over 270 long-term care providers across the Commonwealth. Hopefully in your packet, you will see a one-page document which lists the current levels of long-term care in Kentucky. We thought, well, actually Dr. Alvarado thought, that this information would be helpful to you to start today's discussion. You will see that skilled nursing facility level of care is the highest level of care. Personal care is the second highest level of care, and assisted living is currently the lowest level of care. On the sheet, you will also see that these levels of care, how they are reimbursed. And in Kentucky, only skilled nursing facilities are reimbursable under the Medicaid program. Today, you'll hear a discussion on the proposed changes to the long-term care continuum. Thanks mostly to Mark Lee here, who is a consultant on this project. You'll see that in Bill Request 137, does not address reimbursements for these services. So that will not change. Medicaid will continue to be only reimburse for skilled nursing facility care. What it does address, it is modernizing the service delivery to make long-term care services more consumer-friendly. It will allow the average consumer to understand how these services are offered and delivered in Kentucky. What you will also hear today will be recommendations to change the levels of care. And so what is outlined on the sheet in your packet today will hopefully not be the reality next year. The nursing facility column will remain the same. The personal care column will change, and what will only be left is what we often refer to as state supplementation personal care, and I'll get to that at the end of my presentation. And all private pay personal care services will move to the assisted living category. All assisted living will move from a certified category to a licensed category, and there will be two licensure categories, which Mark will go into more detail in his presentation. And finally, I want to end, because I know this is very important to Representative Moser, but what will remain in the personal care category are our state supplementation personal care homes and specialized personal care homes, typically caring for a younger population and those with a severe mental illness. These individuals are also typically living below the poverty level. And although we believe this bill, and we thank again Mark Lee and Bob White for listening to our association, because we do represent a large population of state supplementation personal care homes, they did listen to us, and you'll see in Section 37 of the bill requests that it does address state supplementation personal care homes. However, it's a good start. We will continue to advocate for these personal care homes, and we appreciate the General Assembly including funding increases in the last two budgets. So that's just an overview, and hopefully if you have any questions about that one page in your packet, I'll be more than happy to answer that. If not, I'll turn it over to Tim Vino.
Good afternoon. Thank you, Chair Lady and members of the committee. I'm very pleased to be here. I plan on being very brief, as I know there are other folks that you all are prepared to hear from today. My name is Tim Vino, and I'm the president of Leading Age Kentucky. We are based in Louisville. We are affiliated with Leading Age National, Washington, D.C. Leading Age Kentucky also represents the full continuum of care of service providers to the elderly and disabled, including assisted living, personal care, skilled nursing, and other long-term care health categories. The vast majority of our members are nonprofit. Today, I'm here on behalf of our board of directors, pleased to voice our support for BR 137, pre-filed legislation sponsored by Dr. Alvarado. Simply put, BR 137 modernizes assisted living in the Commonwealth. BR 137 also puts Kentucky on par with most other states that also have a basic health care assisted living model. BR 137 also seeks to eliminate consumer confusion when seeking services, oftentimes challenged to differentiate between personal care and assisted living. BR 137 also responds to consumer demand by allowing assisted living to provide more services, thereby allowing residents to remain in the least restrictive setting for a longer period of time. I've seen many good pieces of legislation in my day, I don't guess I've ever seen a perfect piece of legislation. BR 137 is a good piece of legislation and worthy of your serious consideration as we proceed into next year's legislative session. I'm sure there are many points of view regarding BR 137, and I know that we will hear from some with differing points of view today. But from our perspective, we look forward to working through the process and those various points of view as we move forward to next year's General Assembly. Thank you, and we look forward to addressing any questions or concerns.
I think I'm up next.
Yep.
Is that correct? Again, my name is Mary Lynn Spalding, and I'm president and CEO of Christian Care Communities. We are the largest faith-inspired provider in the state of Kentucky, and I'm actually in Bowling Green today. So I appreciate the opportunity to come in and speak and the opportunity for Zoom. And I really am grateful and thank you for that. We too are in support. I'm very grateful to Mark Lee because we have worked alongside Mark in crafting this piece of legislation. To Tim's point, there is never a perfect piece of legislation, and I would tend to agree with that. But from our perspective, when you look at the day-to-day, the workforce, our residents, their families, and particularly people with Alzheimer's and dementia, this goes a long way. I've been working with Christian Care for about 12 years, not quite 13 actually, and Christian Care has been around for 137 years. And we have all levels of care. We have independent living, we have assisted living, we have personal care, and we have skilled nursing. As a result of that, the word consumer confusion is out there. And usually it's at the time that individuals need this service most quickly. We deal with many individuals that live out of state, and our current system is very different when we talk about assisted living than what they're accustomed to in other states. To Tim's point about putting this on par with other states, it allows us to better define what we're able to do in this particular area while still maintaining what we currently have, which is more of a social model. So it's very helpful to families. It will also be very, very helpful to residents. We talked about the fact that people want to be in the least restrictive level of care. I've seen time and time again, and many of my colleagues and other providers see that when folks get to a certain level of care, they can no longer stay in what they consider their home in assisted living because we're not able to provide those services. Transition is difficult when you're young. It's even more difficult when you get older. It exacerbates their medical conditions. It exacerbates their emotional conditions. And this particular piece of legislation begins to address that. So I think it's a really good thing for the residents themselves. And something that we've all been talking a lot about lately is workforce. Many times we will recruit individuals into assisted living to work in assisted living, and they may have worked in different levels of care. They may have worked in skilled care, but the one common theme that we try to find in them is that they all love grandmas and grandpas. And the reality is that when they come into the assisted living setting, it is quite confusing for them to know what they can and can't do because of the current differences between the social and medical models. This bill begins to attempt to help redefine that, in addition to allowing training and more resources for those particular individuals. And then last but definitely not least, which is near and dear to my heart because I had a mother with Alzheimer's, that we see many, many times that individuals will come into assisted living in a social model setting, and they may need medication reminders, but then it quickly turns to medication administration. That ends up posing as a problem currently, and again, results in a transition. We're one of the providers of the Best Friends approach. Best Friends was birthed in Kentucky. It's been around for nearly 40 years, and it's predicated on giving people a quality of life with their life story. Our staff learns more about their life story, and if we're able to keep them in the same setting, it will allow us to better care for those individuals, use that life story, and improve that quality of life while still being able to adjust if we have to administer medications. So with all of that, Christian Care is in support of this particular piece of legislation. We look forward to working with any groups on it, but we're very thankful, and again, very thankful to Mark because he did put forth a lot of effort in getting this to the table.
Y'all are being too kind. I'm Mark Lee. I'm privileged to be here, and thank you for the opportunity to share just a few thoughts with you. I'm not known for my brevity, but we're going to break the mold today. We put together coalition partners, and it's comprised of all three of these associations that you see represented before you today. And we knew that no one association should bring all the views or would necessarily bring all the views. Over the last 2 years, and it's been a lot of people involved, we've studied the assisted living statutes and regulations really from across the country, most of the states in the union. We've sought input from stakeholders, including the Alzheimer Association, AARP, the Cabinet, various hospice organizations, assisted living and personal care providers, and probably most importantly, our residents and their family members. I'm also an owner-operator. My company's involved in independent living, memory care, licensed personal care, and assisted living. By way of example, in talking about listening to that input after seeking it, the Alzheimer's Association, and we're very grateful for it, recommended during our first meeting, recommended that we carefully review the new Minnesota assisted living statute, and they characterized it as being comprehensive and a great example. We listened. 14 of the 21 new definitions in the Kentucky Assisted Living Bill were strongly influenced by that Minnesota statute. Additionally, 9 of the 11 entirely new sections of the Kentucky bill were, again, strongly influenced by that Minnesota statute. This bill, I'm going to run through very quickly. This bill modernizes Kentucky's assisted living social model to more closely align with the vast majority of states. We're almost on a limb by ourselves when it comes to that pure social model that prohibits direct delivery of any health services to our residents. And our residents are a lot older and a lot less well as they come in today than they were 20 years ago, even 10 years ago. It will allow delivery of basic health services similar, very similar to what is now permitted in licensed personal care. It reduces consumer confusion, as you've heard from the others, by merging private pay personal care with private pay assisted living. It promotes true aging in place, allowing care provided in resident apartments to change, to flex, to meet those changing resident needs without necessitating a move to a different licensed area of the building, unless the resident needs a secure dementia environment or obviously exceeds the level of care and comes to require skilled nursing. The bill would add the assurance that a person receiving hospice care who currently resides in what is now apartment-style licensed personal care will not be discharged simply because they no longer meet mobility-related residency criteria. Again, so long as they're receiving hospice care or other end-of-life services. People in assisted living already have that in the statute. It's not there for apartment-style personal care residents. The bill would allow providers to choose how much care to offer within this somewhat broader definition of assisted living. Should a provider wish to offer basic health services? It may. Should a provider choose to stay just providing that social model? It may. The one exception to that is that the bill requires basic health services be provided to residents residing in a secure dementia unit, as these are our most vulnerable residents. The bill is a vast improvement over the current statutes, both assisted living and personal care, especially as they relate to memory care units. An assisted living community with a memory care unit would have a slightly different license. It would be called that the license would read assisted living community with a dementia care. And there's lots of higher standards that are built into that specific to that dementia care unit. Delivery of basic health services within a memory care unit will be required, as I indicated, which will increase quality of care. The bill increases required staff training related to dementia. And these improvements better meet needs of this vulnerable population. They address concerns about the social model memory care units under assisted living that are currently across the Commonwealth. And those concerns have been raised by the Cabinet for Health and Family Services, by the Alzheimer Association, and frankly, this bill aligns with recommendations of the General Assembly's Alzheimer's and Dementia Workforce Assessment Task Force. That was the first thing we looked at as we began to delve into the memory care portion of this bill. The current prohibition on delivery of health services was listed as a very significant problem in the 2019 Task Force report. This bill updates, it modernizes assisted living, not its payor source. Assisted living will remain a private pay, consumer-driven, non-institutional model. Thank you.
I'm Bob White. I'm the Executive Director of Bob White, Executive Director of Kentucky Senior Living Association. We are the state partner in Kentucky for Argentum in Washington. I believe in your packet you have a letter there from the president of Argentum supporting this bill. It's also signed by Pat Malloy, who is a Kentuckian, and is chairman of the Argentum board this year. Pat Malloy helped start Atria a number of years ago. I would like to reiterate that any community that is certified assisted living may remain to operate as a social model, as specified in the bill. 60% of our members would be considered small business, and some people have said that this would be bad for small business. In Kentucky, 60 or fewer units in that small company criteria. The other 40% are operated by the large chains in Kentucky or in the country. Regulatory oversight is not specifically stated in the bill. The Cabinet for Health and Family Services would determine what agency would regulate assisted living. Our association has 129 senior living members, either assisted living or freestanding apartment-style private pay personal care homes, and 128 of those members are supporting this bill. Thank you all for your time today, and we'll welcome any questions or comments you might have.
Well, thank you. I just want to thank you all for all the work that you've done on this. This is certainly an area where, as was said, there's a great deal of confusion about the levels of care that are currently allowable. And I agree that it is time that we modernize and clarify some of those services. And, also allow a smoother transition to higher levels of care. And, it's no surprise that, as we age, we will require higher levels of care, and it makes sense to allow individuals to age in place. It is stressful to move. It's stressful for the individuals. It's stressful for their families. And I just really applaud you for the work that you've done. I think that this makes a great deal of sense. And, I think that it'll just provide better care for our residents. So the one question that we have gotten over the past few days, and it's not a new question, but it has to do with dementia training. And I see that we are in this bill are delineating the training happening in the memory care units, but not outside of those units. So is there any training that'll be happening for staff on dementia in assisted living? I mean, we all know that as patients age, dementia progresses. So has consideration been given to that portion of this training and this bill?
Yes. Under current law, under the assisted living statute, and I believe I'm correct in saying in the PC regs, training in relationship to dementia for rank and file employees is one of the components that must be done, and it is being done. I will say this. There are so many important categories to be trained on for all of our staff. Abuse and neglect, how to get people out in an emergency. Dementia certainly is an extremely important one. We've tried to thread the needle as we've looked at this, at raising the bar where we most needed to raise the bar, which is in that area where the folks who have the highest level of dementia will reside in the dementia care units. We also had to look at the cost of increased training, and because this is all private pay. And so this promotes and has increased standards for dementia training. We're open to creative ways of looking at making it even better for all of our staff, whether there's even a dementia care unit or not. But I think we've really put the focus on really increasing the bar for the staff that work in the dementia care units.
Okay, thank you. That does help. We do have a few questions. I'm going to start with Senator Berg.
Thank you, Chairwoman, and thank you guys very much. I think I have some confusion, so I just want to make sure I'm straight because, unfortunately, I've been through this with my father who died of end-stage Parkinson's and my mother who died of end-stage Alzheimer's, and I have had family members on both my husband's side and my side in long-term facilities for years and years. And this idea of being able to stay in place is wonderful. Neither of my parents had that opportunity, but I'm concerned about, for me, it's a matter, I think, of definition, because I think of the continuum of care as being independent living, which is basically like the model I think of is where my mother-in-law was, where you have your own independent units. Then you go to assisted living, which is where you're helped with medication and some activities of daily living, like in making sure you're showered, making sure you've got clean clothes. Mm-hmm. Then you go to personal care, which means, honestly, you can't clean yourself. You need somebody to help you with basic toiletries. And then skilled nursing, which is when you really need actual medical care with RNs. Do I have that wrong, or is that about right? That's about right. Okay. So when you say that assisted living is a social model with no health services, but then I think, sir, it was you that said basic healthcare assisted living model. So I got confused. In the assisted living, you have no certified employees. You're not required to have any licensed or certified employees, and you can't do medication administration?
That's correct, Senator. The law, the current assisted living statute, which was enacted in 2000, says there's a prohibition on delivering anything that is considered under Kentucky law a health service. And matter of fact, there would be the duty to report that to the cabinet, and bad things happen. And so it's a hard red line. And again, even back in 2000, there was the need to deliver more than a true social model approach in assisted living. But it was the state's first foray into assisted living. We have seen over these years a real need for these people that are in assisted living who are entering at an older age and less well to have basic, not skilled, basic health services. And so what we've done in this bill, what it would do, is to merge personal care, the basic health services model, the ability of staff, the ability of that provider to have nurses on staff, the ability of them to use clinical judgment, the ability of that provider under this bill, under assisted living, to be able to assess, to be able to communicate directly with that resident's healthcare practitioner, to be able to receive doctor's orders, to be able to actually administer medications, not simply provide assistance with resident self-administration, which is especially critical when people have memory issues, cognitive issues. So I hope that answers your question. This does not put assisted living into skilled nursing territory, or I'm pretty sure both Betsy and Tim wouldn't be up here testifying for this, since most of their members, more of their members are skilled nursing facilities than assisted living.
So let me clarify. If you're going to be delivering medications and you're going to be taking verbal orders from a physician, what type of training are you required to have to do that under the new model?
Under the new model, in a very virtually the same fashion as personal care. First of all, the Nurse Practice Act is what would define when a provider, depending upon what services, what care they're choosing to provide, that will drive. Do they need an RN or will an LPN suffice? Who can do what? That Nurse Practice Act will drive that and control that.
So, but there will be a requirement for a licensed or certified healthcare staff because they can't fulfill those functions without it.
If the provider chooses to deliver basic health services. If a provider, if assisted living community B
chooses not to,
doesn't have a dementia care unit, wherein they would have to the residents in that dementia care unit, they would have to deliver basic health services. But for the general population in that building or a building that doesn't even have a memory care unit, they can choose to remain social model if they want. I truly believe that the vast majority of the assisted living buildings across this Commonwealth will decide that they do want to deliver some basic health services and will staff and train accordingly, and again, as governed by the Nurse Practice Act.
Okay, so we're basically under this new, the thought concept of independent living, like an independent living facility where, you know, that basically has nothing to do with this.
It does not.
So we start at assisted living, and we start with basically a model. In your opinion, the vast majority of providers will be delivering some basic healthcare services.
I believe we will see that. I do believe that there will be some, especially maybe in some really smaller markets where they and ones that maybe don't have really strong economies where the affluence level is not really high, that they may look at it and say, obviously, if I'm going to hire credentialed staff, licensed staff, if I'm going to obviously have, be training more, etc., I would have to raise my rates, or the bottom line, whether it's a for-profit or a not-for-profit, Tim, is going to take a hit. And so in evaluating that, each provider is going to have the option to look at that and say, do I need to stay social model, or do I have the opportunity to raise my costs, deliver more and better care, but at a somewhat higher cost?
Okay. I think I'm following you.
One more question?
I do have another question, but it's left my mind. So, thank you. I think, I know what I was going to say, Madam Chairman.
Quickly.
Again, my mother died of end-stage Alzheimer's. She was in, quote, unquote, assisted living for almost 10 years. And in a building that had personal care and had memory care. So as soon as they felt like the need was there for her to have a higher level of service, she could without moving. But I would have deemed it essential that all of her healthcare providers had some training in dementia and how you interact and respond to a demented patient. Because, that was integral to her day-to-day care, was that she had advanced Alzheimer's. She was mobile, she knew how to brush her teeth, she knew how to brush her hair, she knew how to put food in her own mouth, but she did not know how to respond appropriately to caregivers and other people in the facility. And if they had not been trained, it could have been a very, very bad situation. And you got to understand, you're hiring people at a very low-paying job with no experience necessarily required, because most of the time these facilities are desperate to get caretakers in there. And I would really urge that dementia care and how you care for a demented patient be required at all levels, because it permeates all levels of care. It is not just for those people who are in a locked unit.
Well, I agree, Senator. And again, training specific to dementia is currently included in the assisted living statute's list of things to be trained on. So I'm sure there are providers that focus on that more than others. We, as providers, need to focus on that even more. And you're right, it is critical. I know we give a great deal of attention to that in my own operations, and I believe the vast majority of assisted living communities already do that.
And will be required to do so under this new bill.
The requirements do not change under this bill as it's currently written, Senator, for the for rank and file employees who do not work on, or if there's not a memory care unit in the building. The training requirements don't change from what the current law is. In some discussions that we have had and with a key advocacy group for these very issues we're talking about, we've indicated a willingness to engage in looking at the possibility of making in this bill the a requirement that from the menu of things that can be trained on, that dementia for rank and file employees, separate and apart from whether they work specifically on a secured unit or not, be a required topic rather than just on the menu to be taught from.
Okay, thank you so
thank
much.
you.
Thank you, Senator. Senator Meredith.
Thank you, Madam Chair, and appreciate y'all's testimony. I'm big supporters of the work you folks do, and I commend you. You do a great job. And my comments and question, I don't want to suggest that I don't favor this legislation, because I do. I think it really is desperately needed. But I think it's interesting we talk about a continuum of care, and that's like in theory. In practical application, I don't think it's there. I don't think it's ever been there. It's too fragmented. It always has been. And I thought this took a great leap towards it, until you said, but there's still going to be some assisted living facilities that will be just a social model. So just from a consumer advocate standpoint, is if I'm looking to place a family member in assisted living, how will I know the difference in will we set up a set of expectations that are here that can't be met because you got a social model that people just don't understand? Aunt Thelma is in this assisted living and she gets these services, but this one over here, she doesn't get it. So doesn't that add to the confusion?
I'm happy to let anybody else handle this, or I'm happy to if you want me to. All right. Senator, it's a good question. And
Great question.
As Tim and I think Betsy, I think we all recognize there is no perfect. I think this is a pretty darn good piece of legislation, but there is no perfect piece. And when you're having to look at various issues, it can impact, as you know, another one. And one of the things, some of these associations own members. Again, if they're in a very small community and it's not a terribly affluent one, if we were to come in with legislation that says you have to change what you're doing, they may have been in operation for 20 years. You have to change what you're doing. You have to take this social model approach and change it to a basic health service model approach. Start hiring nurses, etc.
Excuse me, but I'm not suggesting that. I think the social model is desperately needed. I'm just concerned as how do we educate the public that you've got one.
Thank you for clarifying. I misunderstood your question, Senator. Thank you for that. You know, what it falls back to is in the same way, I guess my best answer to that is to say every business, certainly every healthcare provider, has an obligation to fairly and completely disclose what they do, what their charges are, how they do it, and to that extent, when someone reaches out, whether it's initially by the phone or they come in to learn more about the particular building and its operation, that will absolutely have to be disclosed, no different than today. And I promise you that even within the social model of assisted living today, there are some that have a very low tolerance level for anyone that may start having any incontinency issues. There are others, because there's nothing in the assisted living statute that prohibits caring for those folks. There are others that take that much further. So there are, that's just one example, but there are significant differences even within the social model today. And it's incumbent upon each provider to fairly disclose where their limits are, what services they offer, and which ones they don't.
I'd agree, but when we talk about a continuum of care, again, that's what we all shoot for. But I think maybe a more appropriate goal is appropriateness of care, appropriate level of care. And when I started in the General Assembly in 2017, we had a $10 billion Medicaid budget. Today it's $15 billion, and I think there's enough money there to take care of everybody's needs if we spend it appropriately, but not getting people at the appropriate level of care. And one of the concerns I have, and it goes to Senator Berg's point, is if you have the social model, we know that Alzheimer's, dementia is a progressive disease. As someone who's in a social model starts to exhibit these symptoms, will staff have adequate training to recognize that and be able to make that transition to another assisted living area? And again, the reason I'm asking is Senate Bill 61, which you passed last session, mandated training for Alzheimer's, is tremendous turnover among the staff if they don't have that training, and we just don't want to exasperate that. We've got approximately 71,000 people in Kentucky who suffer from Alzheimer's dementia. It's projected to be 85,000 by 2025. And
yes, sir.
I really see that this is going to be an onslaught of patients that you folks are going to have to deal with. And I certainly think this is a good way to do it. But back to that continuum of care, I think everybody needs some level of training, even in the social model. But the last comment I have, Madam Chair, is it concerns me that there's not an avenue, and this may not be your issue, it may be our issue. There's not an avenue for Medicaid patients. That's almost 40% of our population in the state right now. And it goes back to that appropriate level of care. If they don't have access to assisted living, where are they? Where are they going? Probably we've got many in our nursing homes that don't need to be there at a much higher cost, so that's costing us more. Shouldn't somebody be exploring a model delivery for the Medicaid patients for assisted living? Are you folks doing that? Is there any conversation about that? Has the cabinet ever brought that up?
Actually, our association hired a consultant a couple of years ago, and I have a report that she drafted. Actually, was a former Dale commissioner. That talked about that. About 48% of the states have assisted living as a Medicaid certified provider. And then many more allow for waiver type services to come into the assisted living community. And you're right. I mean, assisted living is very expensive in this state. Personal care is even more. Dr. Berg, my mom just moved to personal care. The price went up $3,000 a month. So I think it's something that we should discuss. I actually had a meeting, I hope she didn't mind me saying, but I had a meeting with Commissioner Lee this morning on another matter, and she said that this is a discussion we need to have. But we wanted to move, I think Mark will correct me if I'm wrong, we wanted to move the licensure categories to align with the services being provided first, and then start having these discussions, because it will have a significant impact on the Medicaid budget.
I support this. I truly do. Again, I want to look very closely at the training requirements with dementia and Alzheimer's. But, and don't mean this to insult anybody, but we're just kind of slapping duct tape on this issue in terms of appropriateness of care, particularly for a Medicaid population. Right. And we seem to have a philosophy, if we do nothing, it doesn't cost anything, when in fact it costs us a great deal. And this is something that truly needs to be pursued. And I feel almost guilty of proving this and say it's just for self-pay patients. You Medicaid patients, you poor people, sorry for your problem, but we really need to address this. But I appreciate your all's testimony today, and certainly would support this bill if we can get it to the finish line. And we all know about this pursuit of perfect legislation, and we know there is no such thing, but the closer you can get to it, the better off we all are. Thank you, Madam Chair.
Agreed. Thank you.
Of course. Thank you, Senator. Representative Fleming, did she have a question? Okay. All right. And Representative Marzian, do you have a question?
I do. Thank you so much. Fascinating. Well, where am I? So I'm going to relay some concerns from the many, many emails I've received from the Alzheimer folks. Number one, they said there's a lack of specified dementia-specific training and competent staff training in the assisted living. And number two, uniformity in requirements and qualifications for providing memory care across the industry. Have we addressed that in this bill, or is that still a concern?
I believe the bill goes a long way toward those very issues. Again, is when you look at that single issue, is there room over a period of time for continuing to raise the bar? Yeah, there is. Sometimes it's tough, as you all will appreciate, to do everything you might want to do in one fell swoop. 20 years ago, a social model was all that was in the cards for this state, frankly, from a political issue. In 2010, we came back, and I was privileged to work on that first bill. I was the primary author of House Bill 444. Representative Western knows a lot about the original bill and House Bill 444, as others of you do. We made improvements in 2010. Now we're here to make some more. And we're taking a bigger bite now because more needs to be done. And this time we're working as a coalition. So, I'm trying to be transparent here, Representative Marzian, and to say I'm a big fan of strong training programs. Be happy to tour you in one of my buildings and show you that.
Great.
There is some value, though, in realizing that one size doesn't fit all from the standpoint of what's in the training, and that just as Mary Lynn Spalding from Christian Care Communities highlighted that they are a best friends approach provider, there are other ways of doing a really good job in addition to that excellent way of training your people and interacting with your residents. So again, that's a needle we've tried to thread. We're still in conversations with the Alzheimer's Association. We're well aware they have some that they would like to see us travel a little further down the road in a couple of areas. They have also said, man, there's a lot of good stuff in this bill.
Right. And I had one more question because, I've been there forever. And can you give me what the today cost ballpark figure for personal care, assisted living, and then skilled nursing? Because I think a lot of us have no idea. I mean, unless you have somebody in, you don't really know, but just ballpark.
Well, it's across the board, and it really depends on where you are in the market. In the smaller markets, you're looking at, for assisted living only, around $3,000 to $3,600 a month. When you get into personal care, that goes up about $1,000. So you're up to around $4,500 to $5,000 a month in personal care, and memory care is even higher than that because of the nature of those units. In skilled nursing, the average, I would say, is around $6,000. Would you say that, Betsy?
Well, Representative Marzan, skilled nursing facilities typically reimbursed by Medicaid, so it's not private pay, and we pay on a per day basis, and it's based on acuity of the patient, so it's on average about $182 a day is what a skilled nursing facility would receive under the Medicaid program. There's a limited Medicare benefit. If you're going to be paying private pay for skilled nursing facility services, you're going to be running out of money pretty quickly because it's very, very expensive.
Thank you so much. I just thought it'd be interesting to see what the updated costs are. Thank you so much.
Thank you.
Okay, thank you. Just to tag on to Representative Marzian's question, so we know that the cost of personal care is somewhere in the ballpark of $4,000 to $4,600 a month. Assisted living currently is $3,000 to $3,600 a month. What do you anticipate merging these models to cost?
I guess my response would be that assuming a given provider decides to embrace the opportunity to provide more care, I think you're probably going to be looking at the range of what PC, personal care, costs on a private pay basis, because the level of staffing, the level of training, the level of those costs are the service level. What can be done is pretty much what's being done in PC today. So that's probably the best barometer I could give. And I promise you, in Madisonville, Kentucky, where we live and have an assisted living community, I'm looking real hard. Does the market bear that kind on a, to your point, Senator Meredith, on a strictly private pay basis, because there is no Medicaid waiver? Will the market bear that? I think we're going to do it. Will it cut into some of our profits because we won't be able to raise rates enough to cover all of those? Likely. But I think it's the right thing to do.
Okay, thank you. Yeah, it seems that, perhaps there's a PRN kind of as needed, cost that could be looked into.
Well, we did write, our representative, we did write into the bill the opportunity, where appropriate, to have on a contract basis some of the credentialed staff, so that if your need for that flexes, a provider can deliver what they must deliver, but not always have to have them 24/7 on staff. And we did that by design, thinking about this very conundrum that I've just spoken to.
I think that's a good idea. Looking into this on a contractual basis, and as folks progress in their levels of care, making it available anyway. Great discussion. I know that we have a lot to talk about. Senator Givens, do you have a question?
Madam Chair, I do, and I'll try to be brief. Thank you, first of all, for the opportunity to have this legislation in front of us in the interim, because this is the ideal way for us to use the interim. It sounds like a lot of work has gone into the legislation, 57-page bill as I got it pulled up and started looking at the BR, so it's a substantial piece of legislation. The one-pager you gave us is very helpful because it struck me listening to the conversation and thinking about the lexicon us lay people use as it relates to these categories versus the actual certification and licensure categories governmentally used. We get it wrong all the time, and we as collectively, both the governmental group and the layperson. But as you well know, a lot of folks will say, well, my family's in the nursing home. There's a big difference.
Yes,
there's
sir.
a big difference, and it struck me listening to the conversation. 57 pages, lots of changes. I'm excited about the conversation. As I read on page 27, you're basically dissolving the personal care category into assisted living communities. Is that what I understand?
Exactly, except for state supplementation personal care, which is they serve a younger population and people with serious mental illness typically, and they're relying on state supplementation, so they're very poor individuals. So this bill would change personal care that's private pay. So if you go to Louisville, for instance, you might see what all of us would think, oh, that's an assisted living community, but it's really a personal care private pay community. So everybody like that would move into the assisted living category and then change that from a certification to a licensure with the different levels of care as Mark described. So there still will be a licensed personal care category, but it is for the state supplementation. And again, I'll use this as a plug, which we need to work on that issue as well.
So that's the third bullet in the second category where it says state supplementation. That would still be siloed in a separate
in personal care.
Silo.
In personal care,
okay,
as it exists today.
Talk with me about some of the changes further on in the legislation as it relates to the assisted living communities now fall in under this umbrella of long-term care facilities based on a definitional change that you have here, but they don't for circumstances of oversight and ombudsman. Why would they want to be there except for those times that they don't want to be there?
The currently licensed personal care does have a relationship with the purview of the Ombudsman office. For 21 years, assisted living has not. And it's the way the General Assembly passed it, seeing it, because people for these last 21 years have had their rights protected and by having a lease agreement, as opposed to in a what I'll call a nursing home model. There typically is no lease. There's an admission, and there's not a specific legal document, and so that is the way assisted living. And I would suggest to you that the reason assisted living as a category, as a brand, if you will, enjoys the level of support statewide that it does is because assisted living providers have done a really good job with that model. And that lease being in place will not change under this bill. And so folks are still have been being protected. And I would suggest to you that in Kentucky, and this is not to throw stones at my brothers and sisters that have skilled care, but I think if anything, we may have heard about fewer issues of a negative nature in assisted living. I think we haven't heard a lot about those. So that's the best answer I can give you. That simply hasn't changed in this bill from what it's been for 21 years in assisted living.
I think you can understand my concern, and it's a well-intentioned concern. If you want to move into the space, there are things about the space that even the people in the space probably don't like. So that may be an ongoing conversation we need to have.
All right.
Thank you.
Thank you, Senator.
Okay, thank you. Representative Elliott.
Thank you, Madam Chairman, and forgive me, I haven't had a chance to read the bill, but is there anything that's related to tort reform in this bill?
One word answer, no.
Easiest question you're probably going to have today, so thank you.
Great, thank you. Representative Sheldon.
Yes, thank you very much. Quick question. As I begin to think about some of the consequences of maybe, first of all, it's a great bill, and thanks for all the work. But I'm trying to put myself in a position where you said you were from Madisonville, one of you, and that was an area that's not necessarily an urban area, and that you were going to have to make some tough decisions. And that led me down a road of thinking about healthcare access. Kentucky, as you know, we all know, is one of the largest rural states in the country, and we have a lot of areas that are really concerning when it comes to healthcare access, and that would also, I think, flow over into personal care homes and assisted living as well. So, I guess, can you come up with a scenario where there would be a smaller community and maybe a personal care home is there, barely kind of making ends meet, but they are serving the community, and then all of a sudden we come along and say, if you want to offer these other healthcare services, including dementia type services or whatever, you're going to have to, have these extra expenses of which you spoke of eloquently earlier, that you were going to have to even weigh out for yourself. So, do we see this as possibly causing some homes to have to shut down in rural areas because they couldn't afford to upgrade, and or they would lose some business to people that could upgrade? Can you give me that scenario, ease my mind a little bit?
I'll do my best. If I heard you right, you talked in terms of a personal care facility in a smaller community like you were describing. If it's a personal care community now, apartment style, private pay, what we're talking about that would bridge over and become assisted living, they already are delivering the level of care that we refer to as basic health services. So my answer to that is no. However, I think really probably what you meant to be asking, it's a terrible way to say that, but I think what you meant to be asking is, what about an assisted living community?
Yeah, I'm sorry.
And that is part of the reason that we felt it important to preserve that provider's right to stay social model. If they couldn't up their game, as it were, and layer on those additional costs and be able to charge appropriately in order to not go into the red. We felt that was critical, and I really should have woven that into my earlier discussion, so I thank you for your question. It's not just about provider choice, it's about access and preserving those small assisted living communities that might be struggling, especially right now, with having come through COVID, with that depressed occupancy at virtually everybody's place. Preserving their ability to look at it and say, I'd love to deliver more care, but in my market, can I do that? Can my current residents, can future residents afford that? And that's the reality of it since, and I'm looking at you, Senator Meredith, since assisted living doesn't have access to any Medicaid dollars. And again, for those of you that are concerned about that Medicaid budget, we're not coming asking for that. That's not what this bill does. Are we interested in participating in those discussions at the right time? Yeah.
Thank you so much. Could I have one follow-up, please?
Yes, quickly.
Thank you. And I'll go quickly. So you don't see any scenario where there would be smaller operations that would simply have to just, for whatever, whether it be assisted living, as you corrected me, you don't see possibilities where they just say, I can't handle the increased cost of training, and when they don't do it, they would lose some of their residents to other people. You don't see any smaller operations being, having to shut down. Is that what you're saying?
I do not, because of their ability to stay doing business as they are. Even though in a perfect world, we might like to see all of them delivering basic health services. But for the reasons you raise, no, I do not.
Thank you very much. I appreciate that. And yes, you have eased my mind. Thank you.
Yes, sir.
Okay, thank you so much. We have a couple more minutes on this topic, and then we're going to have to move on to our next topics. This is a great discussion, though. Thank you very much for putting up with us. We have a question from Representative Birch. Can you turn your microphone on, please, Representative?
Is this a sponsor industry legislation that you're pulling together, or does the cabinet work with you on this legislation?
We've engaged with the cabinet. The initiative began, frankly, after some conversations with the immediately preceding, that's not the right word, but with Steve Davis, who was Inspector General under the previous administration. Conversations began then. There was a real interest at the cabinet, and they saw a need for some realignment, and the cabinet has shared some of the very concerns we've had about that confusion in the public between PC and AL, and they have had concerns over there being assisted living social model dementia care units and personal care dementia care units. Some you can deliver basic health services, others not. And so we engaged with Mr. Davis. What was that, Bob, the first time? 18, 19? What? And then have continued in conversations with Adam Mather, the current Inspector General, with Secretary Friedlander, and others at the cabinet. And so I'm not going to say this is the cabinet's bill, but they've seen it before it was pre-filed by Senator Alvarado. We've engaged in conversations with them, and as a matter of fact, we've got another meeting tomorrow with them to continue those discussions.
Do they seem like they're going to be supportive of it, or can you tell?
We have heard, I have heard, y'all jump in if you see it differently. I've heard nothing that they've specifically pointed to where they said, you know, that's a bridge too far. We can't go there. We disagree with that in terms of specificity. I think they haven't said yet we're going to come out and support this, but they sure haven't said we're going to fight you on it. So
well, the reason I asked that question, if we get here during the session and then we got a cabinet raising hell with you about this thing, it's going to put a bad taste in a lot of people's mouths. It's better to go in with all the parties wanting to at least be for it, or maybe accepting some of the suggestions that they might make in order to make it more palatable to them.
I understand, Representative, and that's why we've been in conversations with them as well as other important stakeholders and continue to be. I hear you.
There's one other thing. Representative Morrison asked what it cost, but I can tell you from personal experience. My sister was in fact, she just died in February. She was in the nursing home for about 3.5 years. And it's not that she couldn't get up, she just would not get up. She was afraid she'd fall. So she had to have some of the services that we'd ordinarily not go to a person in her. Her bill was between $10,500 and $11,500 a month. So it's not cheap. Right. Fortunately, she had the resources to take care of that. But hers would not have lasted another couple of years.
Right.
At that rate. So, but I would hope that you all would get with Friedlander and that group at the cabinet and try to bring this bill as where there's cooperation on all sides. If not, it may have difficulty.
Representative,
they may pass it out of the House and Senate, but it might run into a problem with how you're going to pay for it. And
that's one of the reasons.
Is it going to cost more to implement this?
Well, that's one of the reasons we're meeting with them continually.
I think that's a good idea, but you do it before January before the budget's finished.
Yes, sir.
Thank you, Madam Chair.
Thank you. Representative Westrom, you have not had a chance to chime in here.
Well, this should be a simple question. I'd like to know, I know there is no shortage of the senior population growth. And it seems to me as that population continues to grow, the different levels of care will be needed. And so what you're doing is very progressive and looking towards the future. Can you tell me what the senior population growth looks to be over the next 20 years? That may be too exact for you, but I haven't seen any information on that for quite some time.
Interesting you should ask. I just completed and gave a report to the client last week, a week ago today, on a market study that addressed some of those issues. We're going to continue to see a climb at least until 2050, and some beyond. It looks like, and I think I've got my year right, about 2050 it starts to level off a little bit, the projections that I've seen, the ones that come from Claritas and the Census Bureau, et cetera.
Well, maybe in 2050 we will need more child care services that will be available. Thank you.
Thank you.
Okay, thank you so much. Great conversation. I know that we're going to be talking a lot more about this during session, but I appreciate your coming today and giving us a preview and allowing us to have some of our questions answered. I think that, as we talk about streamlining some of these licensure categories, obviously some of the questions about standards of care and training to get there, and then, once we have this model in place, disclosure of exactly what the models of care are in certain areas is going to be important to families.
Agreed.
Well, thank you so much. I appreciate your time.
Thank you.
Okay, next we will hear from Mackenzie Longoria with the Alzheimer Association, and I don't know if you have anyone with you, but introduce yourself for the record and welcome. We look forward to hearing about your priorities for a few minutes here. Thank you.
All right, green light is on. Thank you all so much. My name is Mackenzie Longoria. I'm the Director of Public Policy for the Alzheimer Association Greater Kentucky and Southern Indiana chapter. Just very briefly, Representative Westrom, in response to your question, there's about 54.1 million adults over 65 and older in the country right now. That's projected to be about 81 million by 2040 and about 95 million by 2060. So I had that for you since you asked that question. So most of you on the committee, if you know me, I'm not usually one to read from a prepared statement. It's not usually my style, but it's an important topic today, so I will be doing that to stay concise and to the point as much as I am able to. So Chairwoman Mosier and members of the committee, I want to thank you for inviting me to speak to all of you today. I was asked to present to this committee regarding the Alzheimer's Association's priorities and goals for the upcoming legislative session and the fiscal year. The association has several important goals, including training for APS workers and securing a small amount of funding for the newly established Office of Dementia Services. But as of today, and with the pre-filing of BR 137, which to your point, Representative Elliott, who has left, was unfortunately not included on today's agenda, that is the primary focus of the association. And our work will be to ensuring that vital changes are made, reflecting the needs of more than 250,000 individuals living with dementia and their caregivers in our Commonwealth before this legislation becomes law. So it's important to note that the association wants to be in a position to support this bill during the regular session and work together to improve the assisted living landscape in Kentucky. However, the current iteration of this bill is not a bill that we can support, and we are asking members of this committee to insist that all stakeholders work together to create parameters for assisted living licensure that enables the industry to supply critical living services while simultaneously considering the needs and safety of all residents. Our current system is not perfect, as we heard, and the association recognizes that it is past time to move away from a certified social model only system. Coupled with the confusion over today's versions of personal care homes and that nearly every facility is seeking to provide memory care, we recognize that it is a difficult system for consumers to navigate when deciding where to place a loved one. However, replacing our out-of-date system with another deeply flawed system is not the right course of action. This is a once-in-a-lifetime opportunity to create a new and better model so that we're not back here in 10 or 20 years. But we must have consumer input from all other senior-focused advocacy groups, and above all, it must protect residents and staff in all assisted living settings. Before I address the specific areas in which the Alzheimer's Association has concerns, I want to first provide some brief background on how this process unfolded. The Alzheimer's Association was consulted regarding this legislation, first in early 2020, and then during a coalition group meeting held at the Alzheimer's Association's office in July of 2021. During that time, the association's areas of concern were presented to the group representatives, and the association shared other state models and specific language. While the industry acknowledged receiving this feedback, no other meetings were scheduled and all conversations ceased. I also asked that other stakeholders be included in these conversations, and it was our understanding that collaboration and input were valued and would be part of this work. That is why I and others were surprised and disheartened to see this draft filed. The Alzheimer's Association is the leading expert worldwide when it comes to caring for people with Alzheimer's and other dementia. And let me also mention that this disease does not happen in a vacuum. Other chronic conditions like heart disease and diabetes increase your risk of developing this disease. And may I also mention that 94% of Kentuckians ages 40 years and older that have reported some instances of cognitive decline have another one of these chronic conditions. It is the job of the association to be the voice for the 6 million Americans living with this disease, and it is my job to be the voice for more than 75,000 Kentuckians with this disease. That is why the association is unable to support this bill until the following areas are addressed. Our first concern is regarding dementia-specific training in the general assisted living community. I also want to point out that this is an element that was present in the Minnesota legislation that was referenced. In fact, there were 21 different areas that were included in the Minnesota legislation, but as you heard, only 14 of those were selected. The Alzheimer's Association recognizes there are provisions of this bill that do address training and education for assisted living communities with dementia care. However, people with dementia reside in all long-term care settings, not solely in memory care or in dementia care assisted living communities. Therefore, it is imperative that staff in all assisted living communities receive dementia-specific training. There's been a lot of conversation about what current statute said, and I was just going to summarize it, but I believe it has been vastly misinterpreted, so I am briefly going to read this word for word. The current applicable statute is KRS 194A.719, In-Service Education for Staff and Management. Assisted living community staff and management shall receive orientation education on the following topics as applicable to an employee's assigned duties: client rights, community policies, adult first aid, cardiopulmonary resuscitation, abuse and neglect, Alzheimer's disease and other dementia, emergency procedures, aging process, assistance with activities of daily living and IADLs, particular needs or conditions, assistance with self-administration of medication. That's 11 topics with language that is very broad and leaves it up to the discretion of the employer to interpret whether or not they need to cover certain topics for certain staff. That is not required dementia-specific training. In addition, the statute also describes the in-service education that someone has to receive. Assisted living community staff and management shall receive annual in-service education applicable to their assigned duties that addresses no fewer than 4 of the topics listed in subsection 1. Again, this only requires that 4 of the 11 areas be covered, and discretion is left up to the employer as to what topics to cover. And in both of these sections, there are no hourly requirements. With over 40% of residents in regular assisted living communities struggling with Alzheimer's or another dementia, it is critical that staff serving them have the basic dementia training they need to provide quality care. Let me be clear. The association is not asking for every general assisted living facility to meet rigorous, expensive, and time-consuming standards. However, we do believe that establishing a minimum level of training is essential to providing any care to this vulnerable population. Many providers already recognize the need for this training, and that recognition was mentioned again today. In a meeting with the coalition partners, one member even stated that he could, and I quote, count the number of our members on one hand who aren't already providing dementia training, end quote. That would seemingly negate the cost concerns. The coalition acknowledged the importance of dementia training by providing updated statutory language to KRS 194A in a previous draft of the bill that they sent to me. That language including the following additions. As the statute reads, prior to independently working with residents, assisted living community staff and management shall receive orientation, education addressing, quote, all, end quote, of the following topics, quote, with emphasis on those most applicable to the employee's assigned duties, end quote. Additionally, in reference to the in-service education, they further added that staff members shall receive annual in-service education applicable to their assigned duties that addresses no fewer than 4 of the topics listed in subsection 1, quote, one of which shall include Alzheimer's and other dementia, end quote. That language, however, is not found in this current bill. There is a great deal of conversation around the issue of healthcare workforce shortages, staff burnout, and staff turnover. Members of this committee asked me what the Alzheimer's Association recommends to address some of these issues in long-term care, and the answer is simple: a dementia-trained workforce in all long-term care settings. The second area of concern for the Alzheimer's Association, and something that Representative Marzian brought up but was not addressed, is the creation of a new assisted living community with dementia care license. The bill lays out several requirements that a facility must meet before being issued a license, including addressing education and experience in managing residents living with dementia. This section represents some of the best practices from the association. However, these critical sections only apply to, quote, initial licensure of assisted living communities with dementia care and do not apply to existing dementia units in operation as of the effective date of this act, end quote. The same provision applies to personal care homes that have existing dementia units in operation. While the Cabinet is required to conduct an on-site inspection prior to issuance, the focus of that inspection is limited to ensuring compliance with the physical environment requirements. Based on a review of the Department for Aging and Independence Living most recent list of assisted living facilities that currently have an active certification, it is estimated that minimum 60 out of 135 active facilities, nearly half, would be exempt from these education and experience requirements that we are creating. I want to pause here and acknowledge that I know there are fantastic providers in our state who have the education and experience to provide exceptional dementia care, but there are providers who do not. Facilities providing dementia care and with dementia care units, whether they are personal care homes or assisted living communities, should have a uniform standard across the industry when it comes to qualifying for licensure under the dementia care license. Providers who are doing exceptional care should want to showcase that essential expertise, and furthermore, they should want an industry standard that commensurates with their excellent quality of care. The management of residents with dementia, especially those who consistently engage in exit-seeking behavior, have behavioral issues, or are frequently combative, is complex, and there are specific methods for effective engagement. For the well-being of staff and all residents, every facility should have to demonstrate some basic knowledge and experience with this population before being given this level of licensure. Throughout my statement today, I have said repeatedly that it is my hope for this hearing to be another step in the good faith negotiation process, that this hearing is used as an opportunity to get this legislation into the hands of all stakeholders, and together we can pass meaningful legislation that will improve the lives of all seniors in assisted living communities. I must also pause here and note that the question of the long-term care ombudsman was brought up. The long-term care ombudsman has not been included on conversations for this bill, and tomorrow is actually our first meeting between the coalition groups and the Department for Aging and Independent Living. As we all know, we are still in the midst of a pandemic that decimated long-term care facilities and disproportionately impacted residents with dementia. Now is not the time to be weak on licensure and training requirements. Now is not the time to be lax on ensuring staff are equipped with the proper training that they need. And now is not the time to have variations in standards among facilities when it comes to residents with such complex care needs. But we do have a great opportunity to work on this legislation and improve Kentucky's long-term care infrastructure. But all efforts we make to address long-term care must seek to improve the services and supports infrastructure, and it must include all stakeholders. I personally look forward to working together and appreciate the committee's support. I thank you once again for your time today, and I welcome any questions you may have.
Okay, thank you so much. You were fast, so that was good.
I can be
and
too wordy sometimes, so I timed myself, Chairwoman.
I appreciate your input into this. Of course, I think it's critical. I'm glad that you have a meeting with the cabinet tomorrow. Just to remind everyone, when a bill is pre-filed, it's the beginning of a conversation, and so it's October. There's time. And so, I think that these conversations are necessary, and I'm sure that your input will be greatly considered. My question is, do you have, I know that you are talking about dementia-specific training, not necessarily a broader category of training that, we all know is necessary when folks enter an assisted living facility. But do you have a general idea of what the cost of training would be? And do you have a model of payment that other states have used that is working successfully?
So it really varies, Representative Mosier. It varies based on the size of the facility and then, how many units of training you need. It varies on whether it's in person, if it's online. For example, when Senator Meredith and I were working on the home health training bill last year, I provided to the cabinet some examples that ranged from sort of the cream of the crop all the way at the top, a model that Florida has invented, for example, that costs about $5,000 for training, all the way down to HHS provides several free modules on the signs and symptoms of dementia, the warning signs, effective communication techniques, et cetera. And those are all free and can be cobbled together to create a nice training.
Okay, so do you have a model of training in mind that you're planning to propose?
So the training actually that is articulated in the sections of the bill that deal specifically with the dementia care licensure is fantastic and really represents a lot of the best practices. Our biggest concern is not so much that assisted living staff, in the general assisted living setting, as this bill would create, aren't having necessarily that level of dementia competency, but we really want to make sure that there's an emphasis on communication behaviors, crisis de-escalation, the importance of verbal cueing so that these individuals can still accomplish tasks on their own, but they may just need some of that verbal assistance. And also some training that focuses on egress prevention, because even if you do have a secure dementia unit, alarms fail or, something doesn't work during a power outage, we have to make sure that staff are still capable of recognizing that exit-seeking behavior and know how to appropriately deal with it before it could turn into a worse situation. So as far as a specific model, we are just, the association prefers that training is representative of our dementia care practice recommendations, because we believe that that gives the most flexibility to providers to choose a model of training that works for them and their employees, but includes sort of our best practices rather than saying, you specifically have to do this method, because something like, Teepa Snow, for example, is fantastic, and her training represents a lot of best practices from the association. So it's important to give providers flexibility when it comes to that.
Okay. Yeah, I mean, there's a lot to talk about. I think when we're talking about creating standards of care, the determination as to who pays for that is important. Does that fall on the private pay facilities, which will trickle down to the families and the residents, or does this become part of training in a nursing school or in an actual curriculum for CNAs? So I think that that there are probably some different ways to look at this and still create some sort of standards. So thanks very much. We have one question from Representative Prunty.
Thank you, Madam Chair, and thank you for your presentation, Mackenzie. You mentioned, other than that all the stakeholders need to be at the table, who else besides the Ombudsman that you mentioned, what are the other stakeholders that need to be at the table?
I would also like to see, for example, AARP included. It is my understanding that AARP did receive a copy of the bill, but their input was not requested. And I also believe it's important to involve individuals like the area agencies on aging. While those individuals do not necessarily operate or run any long-term care facilities, they are an integral part of the care placement process often. And I think it's important that they are understanding what changes may be being made to the long-term care system.
Okay, so those groups and organizations?
I'm sure there are many others. I'm sure Disabled Veterans of America would like to, have some input in this, or at least take a look. And, many of our veterans, are going to end up in these facilities or, on their way to perhaps a veterans nursing facility, but, they may pass through an assisted living setting during that time. So, I'm sure there are other groups as well, but some of those very senior focused organizations come to mind first.
Thank you. And I'm sorry I couldn't be there. I was going to encourage the other group. I was trying to get in on that list, but it was too long. But I knew you were on the agenda, and I was going to encourage them to include you, since many of the topics that were discussed were about dementia and Alzheimer's. But I want to echo what Senator Meredith said about, when I first saw that sheet of levels of care, the one thing that caught my eye was that there weren't Medicaid payment for the different levels of service. And I think we could look at saving a lot of money there. And to Chair Moser's question about who pays for that. So I think there's a lot of conversation that need to be had, but I think appreciate you bringing your voice to the table, and hopefully we can move forward on this. So thank you.
Okay. Thank you very much. I appreciate your being here, and look forward to hearing from you once you hammer out some of these details.
Thank you so much, Chairwoman Moser. Thank you.
Okay. Okay, I'd like to just recognize that Representative Bentley is on with us on his phone, I believe, so that's why we're not able to see him online today. So thanks for being with us. Next, we have a presentation from Lifeworks program, Transition to Work and Independent Living. So thanks very much for being here with us. We have about 20 minutes. So maybe carve out some time for questions if you don't mind, and just introduce yourselves for the record and go right ahead with your presentation.
Thank you very much. Excellent. Thank Thank you very much. So, good afternoon. I'm Dr. Mary Lloyd Moore, Executive Director of the Suzanne Vitale Clinical Education Complex in Bowling Green, Kentucky. And this is Mr. David Wheeler, Executive Director of the Lifeworks at WKU program, and Mr. John Kelly, founder of the Kelly Autism Program and parent of an adult daughter with autism. It's our extreme pleasure to be here with you today, and it's more of a privilege as well. So thank you, Madam Chairwoman Moser, and members of the committee for the opportunity to be here and speak with you today. We are here to talk about the Lifeworks program, as well as to sound an alarm about an unaddressed problem for the Commonwealth of Kentucky. Sally and Tom Hundley had their third child, Jason, in October of 2002. He was a beautiful, well-behaved, easy baby. Life progressed well in their home, full of the business and demands of 3 children with 2 working parents. Life was good. By the time Jason was 15 months of age, his parents had become aware that he was not talking, was not interested in playing with his siblings or other children, would not point to objects to get his parents' attention, had a real aversion to loud noises, covering his ears when he heard particular sounds, such as the vacuum cleaner. After seeking help from the family physician, Jason was diagnosed with autism. Fortunately for them, the Suzanne Vitale Clinical Education Complex was there for them. The purpose of the Suzanne Vitale Clinical Education Complex, or CEC as we call it in Bowling Green, is straightforward: to provide a seamless curriculum of education and support across the lifespan for individuals and families with autism, while providing exceptional evidence-based best practice training for our students. We begin our programming at 15 months of age in the Renshaw Early Childhood Center, otherwise known as Big Red School, moving to the primetime program of the Kelly Autism Program, where we serve elementary, middle, and high school students. And then, when our students are ready for college, we have a Circle of Support program that supports 60 WKU students with autism as they progress through WKU, go through college. There's our friend Jason. Jason has been able to take advantage of all the CEC programming from 15 months of age through the present time, where he is in the Circle of Support college program. The CEC has more than 15 years of experience in positive outcomes for individuals and families served. As Jason strives to be a productive and independent citizen of the Commonwealth, he will have the opportunity to attend our newest addition to the concept of a seamless curriculum across the lifespan, the Lifeworks at WKU program, which is a separate 501c3 that is an outgrowth and continuation of the CEC. I want to make the point here, though, that Lifeworks receives no funding whatsoever from WKU. It's a separate 501c3. Lifeworks is a program that is designed for those autistic individuals who have the ability to move to independent living and become contributing members of our society, contributing to the workforce. And it is a replicable model program for the entire Commonwealth of Kentucky. And so I'm going to ask the executive director of the Lifeworks program, David Wheeler, to tell us a little bit about, not a little bit, tell us all about the Lifeworks at WKU program.
Thank you again for allowing us to be here today. The Lifeworks Transition Academy is Kentucky's only living learning community for adults with autism, focusing on transition. This is a 24-month program that allows young adults with autism to develop and strengthen the necessary skills to live on their own and to obtain and maintain employment. The following is a brief video that provides a good overview of the Lifeworks program.
Welcome to Lifeworks at WKU, a living and learning community for young adults with autism and other learning differences. Located in Bowling Green, Kentucky, Lifeworks is a nonprofit 501c3, offering a variety of programs to support your transition to a life of independence and employment. The Lifeworks campus is situated on half a city block at the foothill of Western Kentucky University and is within walking distance of beautiful downtown Bowling Green. The complex consists of a centralized community building and 3 newly renovated apartment buildings known as the Julie and Gary Ransdell Living and Learning Community. Participants of the 2-year Lifeworks Transition Academy reside in modern townhouse-style apartments that are comfortably furnished and feature a fully equipped kitchen and laundry facilities. Our participants live independently or with a roommate and are supported by 24-hour access to the Lifeworks staff. The multifunctional community building is where participants gather to take classes and enjoy hanging out with friends. The common areas include a comfortable sitting area and a spacious communal kitchen, perfect for preparing and enjoying group meals together. The large multi-purpose rooms are where friends gather for game nights and other fun activities. In our state-of-the-art classroom, participants gather daily to receive instruction in the areas of career readiness, independent living skills, and social engagement. The community building also houses multiple meeting room spaces, private study areas, and our staff's administrative offices. Lifeworks at WKU is a supportive living and learning community where individuals are empowered to realize their full potential and successfully transition to living lives of independence, self-direction, and employment. Come discover what life has to offer at Lifeworks at WKU, your bridge to independence.
Just want to cover briefly what a typical participant looks like. A typical participant at Lifeworks is someone like Jason, a young man or woman aged 21 to 30 with autism. Intelligence levels range from low average to well above average, and their socioeconomic and educational backgrounds are varied. Our program is not a group home or 24-hour staff residential program. Participants begin living in an apartment on their own upon enrollment. Therefore, each individual must possess the capacity, motivation, and level of safety awareness to live independently. We currently have 8 participants enrolled, 4 males and 4 females from across the state, including Adair, Jefferson, Nelson, Webster, and Warren counties. They each have varying backgrounds and education levels, but something they all have in common, as referenced on the slide, is a failure to launch. They've completed high school, some have attended college, but all have remained at home, unemployed, with little or no relationships. Their skills have regressed, self-confidence and sense of direction is non-existent. Another shared commonality is that they have aging parents who have voiced deep concerns about their son or daughter's future, stating, "I'm concerned about what's going to happen to them when I'm no longer capable or present to help them." In our program, outcomes focus on 10 critical areas. Perhaps the most important are employability and life skills. However, we also target a variety of other crucial life areas, including finance and relationships and personal safety. The individualized learning plan for each participant is tied directly to these 10 program outcomes. This is how we do it. For someone like Jason and others, we provide instruction in the classroom and hands-on training and support outside the classroom, in their apartment, in the community, and on the job site. We require and support individuals to participate in community service learning, volunteerism, and employment. We have partnered with area businesses and industries to help boost ongoing workforce development initiatives across the state. We facilitate growth in the areas of confidence building, social and interpersonal skills, and relationship building. Our approach is comprehensive, intensive, and individualized. And then lastly, we offer an option for individuals in our region who would like to commute and participate in classroom instructions only. And we call this our Bridge program. Thank you for your attention, Dr. Moore.
Okay. Thank you, David. Appreciate it. So I would like for us to turn just for a few minutes to some statistics. You all probably know, but the incidence of autism is 1 in 54. According to the Centers for Disease Control. There are an estimated 82,735 autistic individuals in Kentucky. There are 50,303 individuals in Kentucky with autism between the ages of 18 and 64, which is the population, the age population that we serve at Lifeworks.
That is 10,000 more people than in the entire city of Covington, Kentucky, and 10,000 less than in the city of Owensboro. So that's a pretty good description of how many folks we're talking about. Families, it's interesting to note, who have children diagnosed with autism earn 30% less than other families due to the additional responsibilities that are required with supporting their children. It costs $50,000 a year for individual therapies for children with autism who are under 8 years of age. The majority of costs for autism supports in the United States are for adult services, which are an estimated cost of $175 to $196 billion for adults, compared to $61 to $66 billion a year for children. There will be 500,000 autistic individuals aging into adulthood in the next 10 years. Yet, 85% of college graduates with autism are underemployed or unemployed, compared to the national unemployment rate of 4.5%. And a contributing factor to this statistic is the lack of training in job readiness and training in life skills for adult life. Interestingly, the average cost of home and community-based waiver services in 2019, it's more now, but in 2019 it was $48,831. And it's interesting to note that there's been a waiting list for these services since 2014. So we are in a state of crisis in terms of support for autistic adults, and I'm here to we are here to sound an alarm. By age 22, publicly funded education and services cease to be available as families reach what has been called the Great Service Cliff, the lack of support services available for adult individuals with autism. We have a unique need for a unique population that has really not been addressed in our Commonwealth. We get calls from all over the state inquiring about the program. These families are starved for our services, and then when they learn about the program specifics, they say to us, "This is too good to be true and exactly what we've been looking for." We are indeed in a state of crisis, but we have a solution that is cost-effective for the Commonwealth. The tuition of the Lifeworks program is $50,000 per year. These costs are for operational expenses only. The facility has been paid for by the most generous support from Mr. Bill Gatton and Mr. Gary Watkins. Personnel expenses are $985,752 per year. Non-personnel expenses are $401,788 for a total of $1,387,540. Our capacity is 28 participants, with the actual cost per participant being $49,555. There is absolutely no wiggle room in the budget. The tuition of $50,000 is necessary, but it is more than most families are able to afford. We do not intend to be an elitist program, and we need to find a source for support. There are very few programs of this nature in the United States, and there are absolutely no other programs in Kentucky or surrounding states. So as you can see in the slide, our tuition of $50,000 per year is the lowest available of programs that we've researched across the country, with a range of $93,500 per year in Chapel Haven West in Tucson, Arizona, to $57,336 at 29 acres in Dallas. Here's our friend Jason again. This is an issue of statewide emergency and international impact. We have a replicable model program that can help mitigate the problems associated with the impact of autism on individuals and families, and ultimately save dollars for Kentucky. Lifeworks at WKU is the only transition program in Kentucky created to offer the pathway to independent living and working productively, thus providing a vehicle for autistic individuals like Jason that we see right here to be contributing members of society, contributing to the fabric of life, as well as contributing to the tax base that we have in the Commonwealth and the United States. Jason needs your help, and we need your help. We need a line item of budget of $2,800,000 to provide for the Lifeworks program. This dollar amount will provide a runway for 28 individuals to be productive members of society. We can help them to be contributing members of our Commonwealth, able to pay back some of the cost invested in them by the tax dollars they will return based on the salaries they earn when they are employed. We have the opportunity and responsibility to provide assistance for this growing segment of the population that Jason represents to become more self-sufficient. But the tuition of $50,000 is way too steep for most families to afford without help. Would you please help us to offer them a chance at a more independent, productive life, at the same time providing a cost savings for the Commonwealth of Kentucky in the long run? Jason and his family, along with 50,000 plus other families in Kentucky, need your help. And we certainly invite you to come and see us at the Lifeworks at WKU program and visit with us in Bowling Green. We would love to host you at Lifeworks if you would come to Bowling Green to see what we have. Thank you so much for the opportunity to be here with you to describe a program that we think is a solution to a mounting problem, and to hear, I know you've heard the alarm before, but to hear another voice sounding the alarm about this situation that we all find ourselves in. Thank you.
Thank
Questions?
you.
Yes.
Yeah, thank you so much for your presentation. I appreciate that. We do have a couple of questions. I just wondered if Mr. Kelly, if you had anything that you'd like to add quickly in the last couple minutes here?
For the sake of brevity and allowing as many questions as possible, more than happy to get into it. It's a terrible need that we have, but I would want to reinforce from Mary Lloyd's comments the ability to duplicate the technology and the functioning of this program in communities across the state. While it's unique in Bowling Green today, there's no reason that it needs to be unique in Bowling Green within the state of Kentucky. What you need are the kinds of services and the kind of community and local support that we've been able to put together over the years to be able to create these programs. We have those kinds of opportunities right across the state to be able to deal with this. So while we are a pilot and while we are, to many right now, a beacon, to be able to address this program in a very productive, cost-efficient way, we think that it's something that the state needs to look at in a broader sense as far as addressing this issue in the future. It's one of those classic issues of support up front for a long-term gain. That's what I think we're dealing with here to address a problem over the years.
Okay. All right. Thank you. Yeah, your program is certainly impressive, and I know that we have a few questions here. Yeah, I am looking at the three. You said that you have 3 apartments, and you serve 28 individuals.
We have the capacity to serve 28 individuals. We have 3 apartment buildings. There are 8 apartments in each building.
Okay.
Yes.
Okay. Thank you.
We have an administration building, and then there are 3 separate apartment buildings.
Mm-hmm.
Yeah.
Okay.
Just to the north of our administration building.
And that is for the 2-year program that we're talking about as far as the transition housing. The bridge program that David mentioned, which is basically the day program addressing many of the job functions, support functions, to integrate these young people into the business community, is a day program, and that's not including the 28. That will be a growing number based on our ability and capability of addressing.
Okay, thank you for that clarification. That helps. Yeah. Senator Nemes.
Yes, thank you, Madam Chair. How do you equate underemployment? For example, I know a young man that has a college degree, and few thought that he could obtain a college degree. and he is definitely underemployed. I'm partly because employers can't see the potential that he has and what he can do.
Mm-hmm.
They just see, in an interview, you can't see what that young man can do.
Absolutely.
But also, he's probably not capable of doing as much as what people that have that degree without autism could do.
Mm-hmm.
So how do you equate that? I think it would be impossible to equate underemployment, the actual amount of that. And do you all help with getting them proper employment instead of just any employment with like at Kroger or
Absolutely.
McDonald's?
What we do, and I'll let David talk in just a minute, but we provide a person-centered plan for everyone who comes in. And so based upon what they want to do and where they see their future taking them, we work with them, and as well as the businesses in Bowling Green, to provide the appropriate match for job skills, and then we support the businesses once they hire the folks in our program. So yes, David, do you want to add to that?
Just to draw back to what you said, we provide training and support to businesses in our area who thankfully who welcome that, wanting to create a diverse workforce, and they have jobs to fill, and they know these folks have an excellent work ethic. They're going to be dependable, reliable. In my experience, they don't do a lot of gossiping around the water cooler or loafing, and so it's a real plus. And so they'll say, "Hey, could your team come in and work with us on how we can best communicate or work with them or make them feel more comfortable?" And it's been a real positive experience so far with the folks in our area.
Thank you.
Yeah,
a great deal of attention put into the process at the front end to determine capabilities, wants, desires on their part, their family, their expectations, their ability to translate that job into a career and for it to be a self-sustaining career. Again, it's not just find a job for them and feel the job is complete. It is making sure that individual, identifying their strengths and weaknesses, that you're able to work and build to get them in the right slot into something they're productive and comfortable with and feel that they are productive. That's how we feel we can take them from a situation of perhaps today being a bag boy at a Kroger into somebody who's working in an accounting firm or working with a contractor, if they happen to be good at number of issues to get back, to really focus in on the individual. As Mary Lloyd said, that person-centered planning is the whole essence of what this program is about.
Could I have one follow-up?
Of course.
Do you all or can you all help ones that don't need an apartment, that maybe are already out of college, that are looking to do better with their life than what they have?
We can, and we do. We are a vendor with the Office of Vocational Rehabilitation, and so we provide support employment and pre-ETS or pre-employment transition services.
Outside of Bowling Green too?
No.
Okay.
Maybe as we grow, maybe OVR is asking us the same thing, but maybe we can get out a little further. Yeah. Most people in our region say that a lot of the services are really in Bowling Green or maybe in the Glasgow area, but we're trying to reach out to all the areas over time that we offer that.
Okay, thank you. Senator Berg, do you have a question?
I do. Thank you for a wonderful presentation, and I'm sorry I've got a 3:00 meeting, so I'm going to be leaving. I don't need to have these answers now, but I do have basically 4 very quick questions that if you could answer for me in the future, it'd be very helpful. You say there's about 50,000 people in the state of Kentucky between the age of 18 and 64 that sort of meet but we know autism is a spectrum. Do we have an idea of what percentage of those people would be appropriate for a program like
Yes, ma'am,
yours?
75%.
75%.
Mm-hmm.
Second question, out of your students, I guess is because it seems more like a sort of a college program to me, what percent are employed? What percent are able to maintain their employment? And what is the average salary that they're able to, that your graduates historically have been able to achieve? Those are my questions.
We will get the answers to those questions to you.
Thank
I
you.
want to point out this is our second year of being in existence. We were targeted to start during the pandemic, and as you can imagine, we opened nevertheless, but the pandemic.
So I understand there won't be
entered,
much
yes.
historical data, whatever, because really, when you're talking about cost benefit analysis, what I'd like to know is what we're putting in versus what in the long term we can expect to get out.
Certainly.
So thank you, and I'm sorry to
Absolutely.
leave.
Madam Chair, for the committee's information, these folks will be presenting our next Medicaid Oversight Committee meeting as well. So Senator Berg will have another opportunity to talk about this. And I believe you're also presenting to our Budget Review for Human Services
Yes,
Committee
Senator,
in November.
we are, and we look forward to those opportunities. Yes. Thank you.
Thank you. Okay. Thank you very much, Senator Meredith. Representative Sheldon, do you have a comment?
Yes, thank you, Chairwoman Moser. Just very quickly, I'd be remiss sitting about 2 blocks away from the Suzanne Vitale Education Complex, not to mention what these people have done and what they've done for not only this community in Bowling Green, but what they're speaking of now is something that I've been very fortunate to be close with the Vitale family for 35 years, and I have watched this thing evolve into what it is doing today, and where Dr. Moore is taking this is absolutely unbelievable. And I would encourage everybody to come to Bowling Green and take a look at this facility. I've had that opportunity, and I can tell you they're changing the world, they're changing lives right here in Kentucky. So thank you all for what you all do, and I appreciate the presentation.
Thank you for your vote of confidence. We appreciate that. Thank you.
Thank you.
Okay, thank you. Representative Birch, do you have a question?
This is an issue that's not new to me. I helped set up the program for autistic children at University of Louisville several years ago. And at what stage or what functioning is Jason? Is low functioning, middle?
Jason is a low support need, which means he's got the capacity. His IQ is above 85, and he is able to attend the college program at WKU, and so he is a low support need. He is not one of the individuals on the spectrum who has a high support need.
Well, to look at his picture, you would think he looked like my son or your
Of
son.
course.
And,
You can't really
step out and make his mark, and
right.
That's what I say. What you see physically of these people is not really what's going on with them until you understand how we have to do it. I worked for General Electric for 39 years, and we did hire handicap, but you had to be very careful of where you put them, because almost every job in an assembly operation is high risk.
Of course.
And some companies just don't want to take the responsibility and liability of putting a person in a position where they're liable to be hurt the first day they even start. So, we have to have a sympathetic employer. We have to have sympathetic employees who are willing to pitch in and help that individual. And I don't think we're that far along yet with educating employers and employees.
Well, and you make
how this, maybe some businesses are, but by and large, what I've seen in my work experience,
I think you're I think you're exactly right, and I think that's one of the things. And I'm sorry, I didn't mean to interrupt, but I get excited about the program. Please forgive me. That's one of the things that we do at the Lifeworks at WKU program is work with the businesses in the industries to help them understand how to respond and react to our loved ones on the spectrum. And I mentioned the person-centered plan. We would work with the individual to see what was their goal employment and hopefully not get them into a situation that was not appropriate for them to be in. But I think you're so right. Education is key, and we recognize that we need to be better educators, and that's what we seek to do.
Okay, thank you so much. And Senator Meredith, you have a question?
Yes, ma'am. Again, great program, very, very beautiful. I think it's invaluable to a segment of our population that we largely ignored, and that's very tragic. So I think it's wonderful. But I think anticipation of the next 2 committee meetings, I think we really need to focus on its impact upon the Medicaid program. Okay. And I'd be curious, do you all have any thought about a long-term funding model beyond an appropriation from the state? Because I think we've got a lot of fiscal demands that they're going to be hitting this next budget session. And I think this is an investment in a program that will see some savings long term. But I think we have to document that. But I think committee members are going to want to know it's just going to be an ongoing appropriation that we need to consider. So I don't need an answer today, but I think in preparation for our next 2 meetings that you might want to spend some time talking about that.
Thank you for the guidance, and I think that we see this funding for this as a multi-prong approach, and we will define that.
Thank you.
Thank you.
Great program. Congratulations.
Thank you. Thank you.
Thank you. And I had a question really about the funding and creating partnerships, much in line with what Senator Meredith just briefly discussed, but really looking at how scalable your program is. If this is something that you really would like to see across the state, is there an opportunity to partner? You're with WKU. Is there an opportunity to partner with other state universities who receive state funding? Do you receive any support at all from
We
the
do not.
university?
We do not receive any support from the university, but we would certainly welcome partnerships across the Commonwealth, because I think that, as you've heard before many times, we're certainly better together, and we have a model, and we have there's no need to reinvent the wheel, and we have a wheel, so we can put it across the Commonwealth, and we would love to.
I'm all about that.
Yeah.
I love partnerships, and
Me
so
too.
I think that makes a lot of sense. And the universities do receive some state, just a little bit of state funding. So I mean, maybe
True.
it makes sense to.
Well, and we
to
could
talk
create
about that.
could create a model, absolutely, whereby we could. We are separate 501c3, and we do not receive any support from WKU. But that's not to say that we couldn't create a model down the road.
Ways,
Yes.
yeah, there are absolutely ways to create those models. And,
Certainly. We look
P3s
forward
are
to
good,
that,
and
yes.
Yeah.
Okay.
So, all right. Well, thank you so much for your work. I really enjoy seeing the positive things that are happening in our state, and especially as it pertains to populations that we really don't hear a lot about.
Well,
so thank you for your work. You're doing great things.
Well,
I
thank
think
you so much for the opportunity to be here. We really appreciate it. Thank you.
Well, we look forward to hearing more in Medicaid oversight.
Okay, we
So
look
thank you
forward to
very
that.
much.
Wonderful. Thank you.
Okay. Well, see no further business. We are ready to adjourn. I do have a quick announcement. Our next meeting is. Oh, Representative Birch, did you have a question?
A minute.
Okay.
Last Tuesday, I attended a meeting down in Lebanon, Kentucky, with social workers. Senator Hargan actually chaired the meeting down there, but I heard the complaints of social workers. They're supposed to have 25 cases. Some have as many as 80 and 90 cases. They get disciplined because they do not clear these cases. They can't hire people to even fill the jobs that they're quitting faster than they can hire people. In fact, they're quitting faster than we can graduate people. In Louisville, we have over 100 workers short, and you can multiply that across every place in this state, depending on the size of the state of the complex there. But I would hope that and request that you might put that on the agenda before we go into the regular session, because this is going to become an issue. And just as an aside, this past Saturday, I had a meeting at my house and had 15 social workers show up for that, and they're very upset. And I was told that they had 10 people scheduled for an interview to come in for a social worker, and not one of them showed up for the interview. So we've got a serious problem there, and believe me, for a guy that went out, I shadowed social workers for 3 or 4 weeks. These people in harm's way every day. I wouldn't go in them homes with an AK-47, and they go in there with a pencil and a piece of paper. And I think it's serious enough, Madam Chair, that you might want to consider having some social workers come here and testify, and also have the cabinet come and testify how they're going to deal with that issue. Thank you.
Okay. Thank you, Representative Birch. Okay, so our next meeting will be November 23rd at 1 p.m. Here in the Annex. And seeing no further business, we are adjourned.
Hello, Mary.
Hello, hello. How are you?
I'm good. How are you?
Good.
Y'all did it. It was great.
Well,
John
you know
Covington.
John Covington, Andy Covington. Nice to meet you.
David.
Thank you for allowing us to talk. What are you doing?
Ed. We were
Hannah.
just down there Sunday.
Oh, really? Were you really? I saw Hannah at the CDC as I left this morning. She said, whatever you're doing today, have fun. And she was so delightful. Yeah. She's about having fun. Yeah. Well, I love it. I love her hair the way it is. She had that done.
Yeah,
she always
while she was home.
Oh, I love it.
She was home over the weekend.
Yeah. Looks great.
Well, thank you for coming today.
Thank all of you for coming today.
Thank you. Thank you so much, Mary Louise, and thank you for the opportunity to be here.
Appreciate y'all.
Thank you. Thank you. See you later. Thanks for being here.
No problem.
Next Monday.
It's on our calendar. I just got to ask.
I'm Chris with the Medicaid Committee. We had emailed about next week's presentation. We have just two on the agenda. Are these two gentlemen